First of all, I've been asked to cover the subject of inflammatory airway disease, which I'm sure is something that most people are familiar with. It is a bit of a whistle-stop tour, and I think largely the presentation will probably raise some points that lend themselves more to discussion points rather than giving you answers. And the main reason for that is that it's still an area that's very poorly understood, particularly in the racing thoroughbred. So what we hope to cover in the next 15 minutes or so is just some general information on inflammatory airway disease, what are the potential causes, and this is a major area or focus of research at the moment, and certainly planned future research will focus on that. And then literally one or two slides just on any evidence with regard to its effect on performance, and more highlighting some of the problems in addressing that question. It seems like a very simple question to ask and therefore potentially simple to answer, but in reality that can be a difficult question to address, the effect on performance, for a variety of reasons. So IAD really first came to light as a result of the advent of bronchoscopy, or the use of endoscopes in horses, and this really permitted the recognition of cases, and we'll talk about the criteria that we tend to use to define the disease, what we call the disease phenotype, in a second. But as you'll appreciate from that, the outward signs of IAD really aren't very obvious at all, and this is in comparison to another condition previously called broken wind. You maybe know it as COPD, and then it changed to RAO, and we now refer to that as severe equine asthma. Where there's obvious outward signs of difficulty breathing in those horses. So there were, even without a scope, then the diagnostic accuracy with heaves or RAO was relatively high, but a lot of those IAD cases were potentially quite silent. There is some similarities with regard to the disease phenotype between those two conditions, and there's certainly one school of thought that there's a degree of overlap with regard to the underlying mechanism that leads to the disease. And they're both characterized by this, what they call neutrophil rich. A neutrophil is a white blood cell, and normally the equine lungs should be relatively devoid of neutrophils, but in cases of IAD, they come into the airway of the horse along with increased production of mucus. It's a bit of a busy slide, that one, but the reason I put this up is that there have been several attempts to try and define this particular disease since its first recognition. In 2002 there was a Havemeyer funded workshop, and this was really the first attempt to definitively identify criteria to define IAD. And the criteria they used then were that the horses were not systemically unwell. I think if the horse is systemically unwell and it shares some of the features of IAD, then it really doesn't fall into that IAD category, and there's probably another underlying cause for those. And the diagnostic criteria were that there was evidence of poor performance, or at least a reduction in performance, presence of a cough, presence of tracheal secretions with an increase in these inflammatory cells, predominantly the ones that we referred to earlier on, the neutrophil, but not exclusively those, potentially nasal discharge, and a prolonged recovery from exercise, which ties in with the poor performance. And it was accepted at that meeting that there's probably likely to be many causal factors, and we'll go through these later on in the talk, that may act either separately or together, or both, depending on the individual cases that we see. And then in 2007, the American College of Veterinary Internal Medicine produced a consensus statement, and I think it was a very well defined description of the disease, but as you'll see as we go through it, there's some inherent problems there. Firstly, they restricted the definition to lung-derived fluid. That is to say that the mucus that is collected when a horse is scoped down his windpipe and then analysed, that wasn't sufficiently accurate enough. So if people have heard of bronchoalveolar lavage fluid collection, in other words, we wedge the scope within the lung of the horse, we infuse some fluid into the lung and retrieve that fluid. And it gives a much better representation of the cells that are much lower down in the airways. So this definition really concentrated on BAL fluid, the BAL fluid. And there's reasons behind that because it's a lot more accurate. And the relationship with performance is certainly better. It also included functional evidence of lower airway obstruction, so narrowing of the airways in the lung, or AHR is just airway hyperreactivity. That is to say that the horse's airways are tickled up a little bit more than they normally would be, and they would respond to a non-specific stimulus, like cold air, for example, or dust, in an exaggerated fashion. Now, in order to measure those objectively, you need equipment, which is by no means portable, equipment to put figures on those particular indices. So that's another problem with that. And then it also included impaired blood gas exchange. Now, we can measure blood oxygen in arterial blood samples collected from horses. But again, that's something that not most vets will have access to. And when you do measure oxygen in arterial blood, it's something that has to be done relatively quickly after collection. So even though the definition here was much, much more precise than the definition in 2002, the practicalities of rolling that out into practice and onto a training yard were difficult. And then in 2015, I'm not saying that was the only impetus for the update on the consensus statement, but certainly it probably was bubbling under the surface a little bit. And then in 2015, there was another consensus statement update by the same college, which is a little bit more broadly encompassing in its definition of the disease. So they defined it as chronic, more than 4 weeks coughing and or poor performance, which is something that should be evident on the training yard or on the race course, but not attributable to non-respiratory causes. And we'll talk about some of the problems later on in that definition, because a lot of horses that do have a reduction in their performance, in many, many cases, 80% or more, and that's been shown in more than one study, have more than one problem. So just because we find a problem down in the airway doesn't mean that that's wholly contributing to the poor performance in that horse. Secondly, there was evidence of excess tracheobronchial mucus. In other words, we could see that visually just by passing a scope down into the airway, and or an increased ratio of inflammatory cells in lung-derived fluids. So again, you had the option of one or the other. Again, no systemic evidence of infection. In other words, those horses were not sick. They didn't have high rectal temperatures, and there was no increased respiratory effort at rest. That was to differentiate them from those RAO or COPD or severe asthma cases. So it's a much easier definition to follow, but as we'll see, it's a bit of a double-edged sword. The more defined you are in the definition of the disease, then the harder it is to apply those criteria actually to the individual horse, unless you're in a research setting.
Can I just ask about
Yeah, of course.
Yeah, on the evidence of the tracheal mucus, is that something you would see standing, or has that got to be a post-work?
That's a really good question. There's no good answer to that. Probably the best piece of work that's come out that's addressed that question is a study that was done in Sydney in Australia, where they were looking at horses pre and post treadmill exercise, where they were characterizing, that wasn't based purely on mucus, that was also based on their cell count as well. And what they found was they would categorize those horses prior to exercise as IAD positive or IAD negative, set on or based on a set amount of criteria. They would then exercise those horses and they would redefine them after exercise based on the same samples that were collected. And what was interesting was that 80% of those horses, there was no agreement between which category they fell into before exercise and which they fell into after exercise. Now you can live with that, but the problem was out of those 80% of horses, some went that way and some went that way. So some positives became negative, some negatives became positive. So it's really, really difficult to define that. So I would say, in answer to your question, consistency is the key. If you're following those horses through in a longitudinal fashion, then as long as you conduct the procedure with the same preceding conditions as you did before, if you're looking for an improvement in those horses. But it is an area there's not much known about, and even things like transportation will have a significant effect on mucus accumulation within the airway, and not necessarily in a way that you would predict it would. You would predict that it would actually increase mucus, or which it does, or increase inflammatory cells, but it partly depends on the position of the horse's head, whether they're fed hay in transit, all those kind of things. There's a number of factors that really we don't have answers to. So I'd say consistency is probably the key.
And just on the other thing, when you're on the neutrophils, is that something that would show up in a blood test, or is that the only thing that's going to show up in a lung test?
Correct, yes. So those neutrophils come from the bone marrow. They go into the bloodstream. They circulate around in the bloodstream. They have a half-life of about 11 or 12 hours, so they're the kind of spitfire pilots of the immune system. So they don't last very long, and then they go to where they're called to go to try and fight infection or deal with inflammation or something like that. So as a general rule, within the airways, there should be very low numbers if you have a healthy airway. If you find those neutrophils in the airways, then the assumption is there's something that's drawing those in that reflects probably a degree of an unhealthy lung, if you see what I mean. Just to look at them in the bloodstream is not sufficiently accurate enough. So that's like looking at the cars on the M8 to decide what's going on in Glasgow, and it has to be something major going on in Glasgow to determine whether there's a change in the traffic on the M8, if you see what I mean.
If your blood test isn't necessarily showing high neutrophils, that's not necessarily indicative of there not being a problem.
Correct. Absolutely correct. Yeah. Is that okay? Does that answer your question? Yeah. Okay. And then more recently there was another yet another Habermeyer workshop in France in 2014, and there was a number of excellent papers at that workshop, and Ed Robinson, the reason I put this up, Ed Robinson is a kind of grandfather of pulmonology in the horse. At the moment, he's contributed massively to our understanding of airway disease in the horse, particularly the severe asthma form of the disease. But he's quoted as saying, ask yourself, when do I have a little excess airway mucus, perhaps coupled with occasional coughing and reluctance to exercise? And the answer to that question, so that's applying it to ourselves, is when I have a respiratory viral or bacterial infection, or you're in a dusty environment that you shouldn't be in, or you happen to have a predisposition to allergies and you're exposed to low levels of allergens. In other words, as long as we define the disease phenotype in the relatively loose fashion that we have done, then by definition, that phenotype could be fulfilled by a number of different factors. So if you wake up in the morning and you've got a bit of a runny nose, there's a chance you get a viral infection, but who knows, maybe you have something else going on there. Maybe there's a high pollen count. Maybe there's you were swimming the previous day, and some people have that response to swimming. So there's a number of factors that might be involved in this. And they're probably not independent of each other. We probably can't just divide them up and say, well, you're either a dust-related or a bacteria-related or a viral-related. They all probably interact to a certain extent in determining the severity of the presentation of the disease. And then he went on to say that until we know the answer to that question, in other words, which of those factors is important in those individual cases, then we really just have to focus our control of, or focus our attention on the control of dust exposure and the likelihood of those horses developing respiratory infections, whether they be bacterial or viral. But Ed Robinson himself then referred to the work of Markham, who published his work in 1636, who made exactly the same conclusions over 400 years ago, or nearly 400 years ago. And incidentally, he also produced a book saying that English housewife containing the inward and outward virtues which ought to be in a complete woman. So I've already lost about 3/4 of the audience with that. So in other words, it's nothing new and it's not rocket science, and they've recognized this for centuries, that there are potentially a number of factors that might induce those kind of clinical signs that we see in horses. So what are the likely candidates? Well, one is viral disease. It's safe to say that the incidence of viral infections is low compared to the number of IAD cases that we see. So the prevalence of IAD, in other words, the number of cases that we see in a population, it depends how we define it, but it has been, with a fairly loose definition, it has been as high as 80 or 90% in some horses. So it's not an uncommon thing by any means. Whereas when we look at evidence of viral infection, it's considerably lower than that. The two viruses that have been linked with some cases are the equine herpes virus 1 and 4, and this is work that came out in Newmarket. And these are the only ones that have really been linked definitively with some cases of IAD. But even then, it was only in a relatively low proportion of those cases. So it didn't explain all of the cases that we were seeing. Now, interestingly, there's some recent interest in another equine herpes virus, which traditionally is thought to be one that is fairly innocuous, EHV2. And there's some work largely coming out of France that suggests that that might play a role in some cases, either as a direct pathogen or in increasing susceptibility to some of these other agents that we're talking about, so upping the susceptibility of the horse. And some work coming out of the States, recently published looking at equine rhinitis virus A. But there's very much conflicting data. So some would suggest that there is a link to either poor performance or signs of IED. Others would suggest that there is no link at all, and we're just seeing this kind of background level of viral exposure that we would tend to see in almost 100% of the horse population anyway. What about bacteria? Well, there's a wide range of species that are isolated from the tracheal sample, so going back to the windpipe of those horses, and that's a list of them there, but by far the most common one is the top one there. It's called Streptococcus zooepidemicus. Now, that's a bacteria that would normally live around the throat of a horse. So it would be a normal, what we would call a commensal bacteria, but under certain circumstances, it can get a bit of a foothold and become a pathogen, what we would call an opportunistic pathogen. If the environment is right, then it can cause disease, and that's one that's been linked with some cases of IAD. Some work a number of years ago, again from Newmarket, has shown that there is evidence of a biological gradient, and by that I mean they looked at a bunch of horses to determine what was the prevalence of IAD within that horse population, and they divided them up depending on the bacterial growth from the tracheal washes. And they found that those that had no growth, that population of horses, the prevalence of IAD was only 4%, so very, very low. But those that had a high bacterial growth, so this CFU per ml is just a reflection of how many bacteria are in there, the prevalence was 80%. And in between, there was almost a kind of linear correlation. So in other words, it seemed to suggest that the higher the prevalence of IAD, the more likely you are to find lots of bacteria in there. And I've missed out a whole lot of study really in the interim, but and focused on one of the more recent papers by Allison Cardwell, who was looking at national hunt horses, who kind of asked the same question. This was a prospective study. She followed those horses over a 2-year period, and she was trying to identify risk factors for increased tracheal mucus, and that's really how they defined the disease. It was a subjective, as well, semi-subjective measure of increased mucus on endoscopy. And again, what Allison showed was that there was an association between the isolation of 2 different types of bacteria. One is called a non-hemolytic strep, and that's the first time that had ever been shown. And the second was the old culprit, Streptococcus zooepidemicus. And those numbers that I've highlighted in red there, these are the odds ratios, the odds of those horses having IAD compared to a reference population of horses, and showed that both of those odds increased, and when you had both of them together, the odds increased even more, up to 12 times more likely to have IAD. But in Allison's paper, she made a very, very good point, and she asked the question whether this was a chicken and egg situation. In other words, just because you find an association between a disease and your detection or your likelihood of detection of a particular variable like bacteria, the automatic assumption is that the two are linked. And they are evidently linked, but that link might not be causal. It might not be the bacteria causing the disease. It may well be that the disease is caused by something else, like viral exposure or dust exposure. It's resulting in increased mucus production, and that mucus is trapping the bacteria. And the perfect example of that would be cystic fibrosis in people, where there's a very high detection of Pseudomonas, another type of bacteria, in people with cystic fibrosis because they have very thick, tenacious mucus. But nobody thinks that Pseudomonas causes cystic fibrosis, but there's a very strong association between the two. So that's still a question that has to be answered, whether it's a cause or a result of IAD. And then the last candidate that's gaining a lot of attention at the moment is dust. Airway inflammation, numerous studies have shown that it's associated with exposure to dust, some a direct measurement of dust levels, others just predictors of dust exposure like barn confinement, feeding of hay compared to grazing, that kind of thing. Tracheal mucus, again, one of the hallmarks of IAD is associated with particulate exposure. And that's been shown in a number of studies. Probably the most convincing was out of Michigan. Now we know that organic dust-induced disease is well recognized in humans, and there's been decades of research on that, initially among cotton workers, then laterally grain workers, people that are working in grain stores, and more recently still people working in animal housing, particularly pigs and poultry, where there's a high occupational exposure to organic dust, high organic dust levels. So the question is, does it have a role in IED? And I think in order to answer that question or address that question, first of all, you have to ask the question, are there disease similarities between IED and organic dust-induced disease in humans? And if there are there sufficient exposures in the horse? And this is a kind of ongoing process to try and address those questions. Well, there are clinical similarities. We generally see the same inflammatory cell type. So this is the picture up on the upper right there is showing the neutrophils. So these are the neutrophils here, these ones with a kind of lobulated nucleus within them. So an increased number of neutrophils is kind of the hallmark of organic dust-induced IED or induced disease in humans. They have similar symptoms. There's no evidence, or certainly convincing evidence, of an underlying allergic component, unlike COPD. And the mechanisms that underlie the human form of the disease are very, very complex indeed. And as we unravel more and more knowledge about IED in horses, then certainly it suggests that the same is true in horses. There's multiple different types of IED. What are the other related or disease-related similarities? Well, one interesting one is this evidence of adaptation. So in people that have organic dust-induced disease, it's often cited as a kind of Monday morning disease. In other words, they have exposure at the beginning of the working week. Their symptoms are very, very bad. As they work through Tuesday, Wednesday, Thursday, Friday, they become more tolerant to the same level of exposure. Then they have their weekend off, have fun with their family, they come back on Monday morning, and lo and behold, their symptoms are bad again. So there's this short-term adaptation to the same level of exposure. Now, is there any evidence of that in the horse? Well, potentially. We don't really know, but this was a study, again, came out of Newmarket, and this is the same study that I referred to earlier on with the bacteria. And they were looking at the variables here with the time in training. So horses that were in training for more than 6 months, or horses that were in training from 0 to 6 months. And again, with more than 6 months being the reference point, then it would appear that horses that were in training for a shorter period of time than that were more at risk of developing IED. And that's exactly what we identify clinically in the majority of cases. It's those new arrivals to the yard that seem to be developing IED. Now that might reflect immunity, and that's the first point that would jump to mind with anything like that. If you have new arrivals that are relatively naive with regard to exposure to viruses, bacteria, and what have you, they get the disease. It's a bit like kids going to nursery school, and then as they go on through their training, then they develop an immunity. But it also might reflect a degree of adaptation to dust exposures. I don't expect you to read this slide, but the second question is are there, so I think there's a lot of disease-related similarities there. Are there sufficient exposures? And one would imagine not. When we compare the kind of environment we keep horses in with the environment that we keep pigs and poultry in, those very intensive units, then you would assume that there would be quite a marked difference in dust exposures. But this is some work that came out of Eastern Europe a number of years ago and showed that wasn't necessarily the case. With regard to dust levels, they were comparable in some in pig and poultry units as they were in horse units, but on average, if you look at all of the data, they were about 2 to 10 times less. Now, 2 times less isn't that much. And then when they look at endotoxin, which is a component of the dust, again, comparable to some pig and poultry units, on an average 3 to 10 times less. So they're kind of in this similar ballpark as you would imagine. They are less than they are in those other intensive units, but not far off the mark in some cases. And some of the data from this, if you probably can't read this, but the data was taken from horse clinics. These were veterinary clinics or veterinary hospitals. So these were environments that you would imagine would be relatively, or should be relatively clean. And that's certainly pointing to the fact that it's possible that the dust levels that those horses are exposed to can be high enough to cause disease. This is, again, work that came out of Michigan back in 2011, and they were looking at measuring particles over 3 repeated occasions, so they measured them 3 times a day, and they measured them for 3 months of the year, and they looked at 3 different United States racing stables, and they were really just measuring dust levels and see if there was a lot of variation within a short period of time or within a long period of time. And ultimately what they found was that there was a lot of variation, and what seemed to determine the dust levels was things like stable design, as one would imagine, the management of the horses, the season. Obviously they varied quite a lot, the time of day, so they were worse in the morning time, probably where they're being swept out and the yards were being swept, and the location of the stall within the barn. Again, probably relating to ventilation. There's a really nice story they tell where there was one particular barn where they had the very expensive horses around the yard manager's office, which was in the corner of the barn, where you would imagine they're going to be the best looked after horses and the dust levels were going to be lowest. In fact, they were highest. Now, you could surmise as to why that might be. I would imagine there was an awful lot of activity going around that area, a lot of brushing and sweeping going on around that area. But in actual fact, those expensive horses, high-performing horses, were actually exposed to much higher levels of dust than the horses in the rest of the barn. That was in not in a racing stable, that particular one. It was, I think, in a dressage yard. So yes, in racing stables, there are measurable dust levels. What we don't know is how they compare to the levels that are required to induce disease. That's ongoing work. But it's fair to say that what's on the outside gives a good indication of what's on the inside. So even just using the naked eye, going round, running your finger over surfaces, if there's dust lying there, then at some point there's a pretty good chance that that particular dust was airborne. This is one of my favourite slides of all time. So sometimes we're not aware of the environmental health risks around us, as this guy's got his hands in his pockets, not even wondering why everybody's wearing respirators around about him. But again, just looking, just visualising the kind of environment that you're in, I think is sometimes enough. And then the next stage would be monitoring dust levels to take it to the next level. Now, there are some difficulties in quantifying the hazards, largely because we don't really know what level of dust constitutes a hazard is point number one. So there's a poor level of knowledge with regard to the correlations between exposures and disease. And then there's a number of other factors I won't go into too much detail with regard to measuring dust. So what are we interested in? Well, we're interested in the dust that gets down into the lower airways of the horse. So if you just measure total dust, then that might not necessarily reflect what the horses are breathing into their lungs. Most of that might be filtered in their nasal cavity and not actually cause a problem. So we're interested in the respirable dust. So that dust fraction that those Dyson vacuum cleaners nicely compact into the middle section. These are the very, very small particles of dust that are small enough to get down into the lower airways. So we have to address that question as well. The other one is, what is the composition of the dust? In that one dust sample doesn't always equal another dust sample with regard to how hazardous it is. So in other words, what is in the dust that potentially might cause the problem? And the last one, if you're talking about monitoring within your stable yards, is and there was again some really nice work came out of Michigan where they were looking at the comparison between what they call remote sampling. In other words, you put a dust sampler somewhere remotely within the stable versus breathing zone sampling. In other words, you have the dust sampler like these horses here. You have the dust sampler attached to their head collar, so you're effectively measuring exactly what those horses are exposed to within their breathing zone. And there's quite a marked difference between the two. Okay, so measuring dust is, I think, a good idea, but one has to try and set some limits. And it comes back to your point earlier on, it's consistency, that you're comparing apples with apples and oranges with oranges. And that's one of the problems when you go back and look at the data and you say, well, what level of dust exposure is sufficient to cause disease? Well, depends how they measured it, what they measured. Was it respirable? Was it total? Was it distant? Was it breathing zone? And there's not enough data really to try and address that question at the moment. What are the likely benefits? Well, I think the likely benefits, certainly from the point of view of a kind of rather broad assessment of dust exposure, and this is a sampler that can measure real time, so it will give you a real time output and you can go back and retrospectively look at that data. What it can tell you is it can identify short-term elevations in dust. So if you measure over a 24-hour period and you've got no interest in collecting that dust and analysing it, but what you can do is you can go back and you say, well, at what time of the day were we seeing those elevations? And guaranteed it's probably going to be times of the day when there's most activity within the stable yard, when the horses have been swept out, that kind of thing. And also it allows some monitoring of the effectiveness of your management changes. In other words, if you implement some changes to the horses and then you measure that dust level again, even on a longitudinal basis, it would allow you to identify some differences. And an example of that, this was a publication that was recently come out of the States, where they were looking at a bunch of standard bred horses, and they were just simply changing them from horses that were fed without a hay net to horses that were fed with a hay net, and they measured the dust in their breathing zone, and there's a marked difference between the two. Just on that single management practice itself had a significant effect on dust exposures. Right, finally, just finishing off, I think I've spoken enough here. Effect on performance, is there any evidence for it? Well, again, there's a number of difficulties there. Poor performance is obviously one of the criteria that we use to define IED. If we went back to the first slide again, you'll say, well, what are the criteria? Poor performance. So by definition, if they have IED, they probably have poor performance. Then what do we mean by performance? So the guy that's throwing the arrows there, if he misses a treble 20, I'm quite sure you wouldn't blame his lungs on that. But if the athlete isn't finishing in the top 3 racing, then potentially it could be an underlying lung problem. So what exactly do we mean by performance? How do we measure performance? And there's a multitude of problems in addressing that question in racehorses. Another problem is the high prevalence of IED. So if you're looking at something that had a prevalence of about 20%, so 20% of the population are affected, a relatively easy question to answer. But if you're talking 80%, depending on your inclusion criteria that are affected, then it makes it a little bit harder to address whether it has an effect on performance. And as I said right at the beginning, more than 80% of horses with poor performance will have more than one clinical problem. Okay, so they might be lame, subclinically lame, but affecting performance. They may have an underlying respiratory problem, cardiac problem, muscle problem. There's a variety of different things, upper airway problem. And then the last thing is the multifaceted definition of IED. If you were trying to address that question, what is the effect in performance? Well, which factors are measurable? And it may well be that those factors that are measurable, by definition, these are going to be factors that are easy to measure. They might not have any relationship to performance, even though they're within the inclusion criteria for IED. So affecting performance, theoretically, yes. During exercise, there's maximal respiratory function. We'll talk a little bit about this with the EIPH talk, so I'm going to jump through this slide just now. I repeat this data later on. And what is the actual evidence of it? Well, again, the kind of key paper that came out in 2006 was from Sue Holcomb, who looked at horses over the 2002-2003 racing seasons. She looked at 3 variables. Mucus accumulation within the airway, within the trachea, within the windpipe, so just basically endoscopy. She looked at tracheal wash inflammatory cells, so these are the ones within the windpipe, not the lung fluid we were talking about earlier on. And she looked at pharyngeal lymphoid hyperplasia, this kind of little pimples that they get in the back of their throat there. And what they found was that moderate to severe mucus accumulation was the risk factor for poor racing performance. That was the main one. So not really anything to do with the cells, not anything to do with the cytology. It was really the presence of mucus, and again on a fairly semi-quantitative grading system, that was the one that kind of stood out. There was no association, and this is only one study, there was no association between racing performance and pharyngeal lymphoid hyperplasia in the bottom picture there. Tracheal wash cell count, and we can talk a little bit about this later, tracheal wash cell counts and their limitations, and tracheal wash turbidity, so just looking at the sample and determining how turbid it was. And there was a negative correlation between racing success and lung fluid neutrophils. This was in another study out of Ireland, again showing that the superiority of looking at lung fluid versus tracheal washes if you're interested in cytology. So these are the main studies that have kind of addressed that question. So the Holcomb study, the Fogarty study out of Ireland, and certainly the Holcomb study was supported some work out of Australia recently where they were looking at no effect of tracheal wash cell count, but they didn't have enough horses with sufficient mucus in order to address the first question. So our conclusions are, with IED, again, we've probably raised more questions than I've given you answers. There's numerous potential causes. There's an increasing evidence for a contributing role of dust. Others could be attributed, a small number probably, to infectious agents. And as I said when I was talking about Ed Robinson's work or comments, that a lot of these causes will act in concert with each other. In other words, if you have a dust or a virus leading to increased bacterial colonization of the mucus, as we alluded to with the chicken and egg sort of theory, But equally so, you could have infectious agents that lead to increased dust responsiveness. In other words, if they've got an underlying, and you know yourself, if you have a viral infection, you go out jogging in the morning, you're much more likely to cough. That's just a change in your threshold, your increase in your reactivity of your airways. Secondly, there's theoretical and proven evidence on performance. Secondly, only to orthopedic and soft tissue injury. But as I said, there's often coexisting conditions. And finally, increasing efforts to subcategorize IAD will hopefully make things a little bit clearer within the next few years. And these are going to be subcategorized based on a number of factors. And hopefully one of those factors is going to be looking at more definitively looking at dust exposures to say, are those exposures sufficient to cause airway inflammation, and then making the next step to making an assessment on the effect on performance. So I'll probably finish there. I mean, that slide really just kind of highlights that point that we're kind of getting away from this idea now that if you have a horse, it doesn't necessarily fall into one of two categories. Either it's susceptible to dust, i.e. our RAO horses or our severe asthma cases, or it's not susceptible to dust. There's probably a spectrum of susceptibility to dust, and that's exactly what they see in people, that you don't just fall into the yes or no camp. There's probably a degree of a continuum really in susceptibility. And then ultimately the kind of goal is to try and have this all-encompassing definition of equine asthma that will then be subpopulated with subforms of the disease, which would include the different forms of IAD.